Right, so the final section that I wanted to spend some time talking about is really looking at the time descriptors of medications, okay? So we'd already mentioned half-life, but we're going to touch on it again in a moment. But onset of action is something to take into consideration. Onset of action is the time it takes once you take a drug for it to start doing something. So if you take a Tylenol for a headache, 30 minutes later, it works, right? So onsets of action can be very long. They can be very short. It can vary, okay? The peak of a drug is the time it takes for the medication to reach its maximum response. So you might have an onset and it starts to help, and then it just keeps, the benefit or the effect keeps increasing to a peak, okay? The duration of action is how long it causes a therapeutic response for. And then, of course, we have the half-life, which is the time it takes for half of the concentration of a medication to leave one's body. Okay. We also have specificity versus selectivity, and this can get a little bit tricky. So I wanted to spend a moment talking about it. So selectivity depicts a molecule with greater affinity for a receptor, right? How selective is it to a particular receptor? Okay. Does it spill over into other similar receptors? Okay. So if you have multiple serotonin receptor subtypes, is it specific to a singular subtype like 5-HT2A? Or if you keep giving higher and higher doses, does it start to spill into other serotonin receptor subtypes? Right? That is your selectivity. So how selective is it to that receptor or that specific piece of the receptor? Higher doses can affect that. Specificity is the effect. Okay? So specificity is kind of takes selectivity and is one step even further, where no increase, at what point is no increase in the ligand or molecule of interest able to activate the other receptors? Okay, so the effect is very specific. It does one thing, and there's nothing you can do about it. It is very specific. Okay, very few drugs are fully specific, right? So when we give a drug for a specific receptor, we kind of want it in one space, maybe in the brain, but it's going to spill out to other places as well. Serotonin receptors are a great example there. But also, we want to think about pain receptors too, right? So a drug for pain would only bind to pain receptors that are experiencing pain. But we can't do that, right? It doesn't really necessarily work that way. So we have our selectivity to the specific type of receptor, and our specificity, which is the specifics of the effect, and if it's one singular effect and one effect only. Okay, so ideally, we would have very selective and very specific drugs, but those are really, really tough to make. The other piece that I want to talk about, because it's just an imaginarium of how complex and interesting our bodies are and how medications work in our bodies. But we also want to think about something called a therapeutic index, right? So you see your picture here. As I'd mentioned before, the drug dose indicates the poison. The dose makes the poison, right? And this is therapeutic index in a nutshell. So therapeutic index looks at the amount of drug that is required in the system to do the thing you want it to do versus the amount that produces toxicity or is dangerous, right? So it's kind of considered like a margin of error or margin of safety of a product. So things that are wide therapeutic indexes are great because it's hard to accidentally overdose, purposefully overdose, become toxic because something else changed in your body. Big margins of safety are beautiful things. If something has a small therapeutic index or a narrow therapeutic index, that means the amount of medication that it takes for it to do the thing we want it to do and the amount for it to make you feel kind of sick or be dangerous is close together, right? So there's less wiggle room for error, less wiggle room to, go, well, maybe your metabolism changes, but not a big deal, right? So chemotherapeutic drugs tend to be very narrow therapeutic index. We have to dose it very specifically a lot of times based on a lot of factors, including your body size in meters squared, right? So there's some really interesting factors there. Whereas there are drugs that you can take way more than the recommended amount, and it likely will have no negative impact. So the relative safety of the drug is determined to some degree by the therapeutic index of it. Okay. So really, to wrap it up, we've gone through all the basics of pharmacology. So if we use terms, or if you read about terms about things like the metabolism, the therapeutic index, the half-life, it all kind of makes sense when we think about the mechanism of action of a drug, if it's an agonist or an antagonist, if it's high affinity, if it's specific or selective, competitive, non-competitive, reversible, irreversible, how all of these terms play into the characteristics of medications is important in having a, basic understanding of what you're looking at when you're looking at data about medications. I hope this was helpful. I hope you enjoyed it. Thanks for listening.